Hello, and welcome to this CancerLinQ video podcast interview. This is Dr. Bob Miller, Chief Medical Science Officer for CancerLinQ. CancerLinQ is a health technology platform focusing on improving the quality of care and health outcomes for all patients with cancer and advancing evidence-based research. Today, I'm pleased to have with me two of the first authors of a CancerLinQ paper that was recently published in the journal JCO Clinical Cancer Informatics, entitled Chasm Between Cancer Quality Measures and Electronic Health Record Data Quality. We will put a link to the paper in the notes. My guests will introduce themselves in a moment, but I also did want to mention that this was one in a series of recently published papers using CancerLinQ data that was developed by the CancerLinQ Oncology Informatics Task Force, which was an ASCO volunteer group of oncologists and informaticists who have been serving in an advisory capacity to the CancerLinQ board and staff. So thank you, Anna and Rich, for joining me today. If you would please just go ahead and introduce yourselves.
Thanks, Bob. I'm an adult medical oncologist, hematologist, and clinical informatician practicing in the Twin Cities of Minnesota. And I have also had a position as CMIO of OncoHealth based out of Atlanta, Georgia. I have no other conflicts of interest.
Thanks, Rich.
Yeah, I'm Rich Moldwin, lead physician informaticist at the College of American Pathologists. I work on standardized and structured cancer pathology data. I'm trained in pediatric hemonc and immunology, and I don't have any conflicts of interest.
Great, thanks. So let's get into the paper. Let me start with you, Anna. Tell me a little bit about why you and your co-authors were interested in this topic in the first place.
Bob, as you've already mentioned, CancerLinQ is ASCO's platform for data aggregation based on the general principle, record once and use many times. And apart from research, we need aggregated data for lots of other things like quality measures that are mandated by JCO or CMS or others. Historically, this has meant an immense amount of human effort at chart abstraction. So the macro legislation outlines 19 measures for medical oncology. And that seemed like a particularly apt set to test whether the CancerLinQ platform could resolve the measures that was legislated.
Got it. Rich, tell me more about the study material. What was the study material used for the analysis?
Right. So we looked at 63 oncology practices and cancer centers in CancerLinQ, and those practices covered about 1.7 million patients, and also used 8 different oncology EHR systems. For each of the 19 oncology MIPS measures that we looked at the measure text for potential inputs, or which we call data elements, data inputs. That might in principle be found in an EHR system, and which would make the MIPS measure more amenable to automatic calculation by having structured data already present. So a data element is a kind of structured data that we desire to collect for calculating the measure. One example of a MIPS measure is for HER2 positive breast cancer patients that are 18 years and older. What percentage of them were not given trastuzumab?
Okay.
And the data elements, just as an example that we might have to look at for a measure like that are things like patient age, were they treated during the assessment year for that quality measure, their HER2 status, the drugs prescribed and actually administered or taken, and or even harder, the drugs not used or not taken by the patient. So that's just an example. We overall, for all the 19 MIPS measures, we identified 63 unique data elements that would be needed to automatically calculate all of those 19 measures. Coincidentally, the number 63 is the same. The number of data elements we have is the same as the number of practices.
Oh, right.
63, so don't get confused by that.
Okay.
So we mapped those data elements to storage locations in the EHR databases. We looked all over the place in these databases for these 63 data elements in all the various hiding places where it might be. But even if we found a place in the database where that data could be stored as a data element, it doesn't guarantee that there's any data there stored in that location.
I see.
And so the data that we did find for those 63 data elements, we extracted that and pulled them into CancerLinQ, and that's what we analyzed for this study. Anna, would you like to add anything to that?
Sure. As far as the location, we're calling that a data field. And the fill rate for the data fields basically is a ratio. It's the number of patients who had any information in that data field at any time, even once, divided by the number of patients that the practice was managing. So certain kinds of data fields would get filled all the time. For example, gender is filled 100% of the time,
Sure.
or date of birth is always filled. So that's a ratio of 1.0.
So it sounds like the fill rate, a higher fill rate, was something desirable, that you would want higher fill rates because that meant more data that could be interoperable. So great. So tell me more about what were the principal findings of the study when you set this up, Anna?
Well, we certainly weren't surprised that data elements related to billing and patient registration were very high. And actually, most practices had information about smoking status too. Of the 63 data elements, a little more than a third, 38% in fact, were filled at a really high rate, more than 90% of the time.
Okay.
So that was good. But then the bad part is it was disappointing that the practices didn't have data fields filled for most of the elements that would be needed to compute quality measures for oncology.
I see.
As an example, practitioners always use cancer stage as they do their treatment planning. And every one of the EHR systems, the commercial systems, has a field. They have a place where somebody can store that information. Yet overall, only about 33% of those fields did get populated. And there was a pretty big difference. The high for one practice was 60%. The low for another practice was less than 1%.
Wow. Okay. Now, Rich, you mentioned earlier this was with, I think you said 8 different vendors. Did you, and these were, I believe you said these were oncology vendors or other vendors that were in oncology practices. Did you see differences across the vendors, and did you specifically identify the vendors in the paper?
Well, like we said earlier, we did look at 8 vendors, and they included vendors of main EHR systems,
okay,
as well as oncology-specific EHR systems and those who had, oncology-specific modules. And we segregated the data by the vendor, but when we reported in the paper, we anonymized the vendors and put it in random order, not alphabetical.
Okay, so no one could tell who the individual vendor was based on the results in the paper.
Right, and we didn't link them to the number of patients that a particular vendor had recorded in their system, because that might give away the larger vendors.
That makes sense, yeah, okay.
So, as Anna mentioned before, the fill rates were pretty poor. For more than half of the data elements, we found mean fill rates of less than 10%. And so we have a whole half of our chart with all red, with almost no data in it at all.
Wow.
The best filled data elements were averaging over 40% filled, and they were the common stuff for demographic data, vital signs, and general quality reporting that you might find for other things like tobacco and blood pressure and things like that. And those are well filled because the vendors have been doing that for years. Required collection presumably for other kinds of quality measures. However, Anna, you used the stage group as an example. We only had less than 40% of those stage group data elements were populated. And the range was pretty huge. One vendor was, and I think you mentioned what was less than 1% populated for stage group, and another vendor was 60%. And you'd think that they'd be near 100% populated, but they weren't there in structured data. So overall, we found that the vendors performed poorly on oncology-specific data elements with no clear winners for the quality of their structured data. The data was, I'm sure it was there in narrative form, but we couldn't extract it for automated calculation.
So, I guess what really matters is the results on the measures themselves, because oncologists need to report on these measures, under the MIPS program for reimbursement. So you said there were 19 measures that were in this measure set. What percent actually return useful data, Rich, with all these deficiencies you're describing?
Yeah, it wasn't very promising. So of those 19 measures, only 2 of them could be automatically calculated at a high enough level to be useful. We had a very low bar to be useful. It was maybe if we could get 10% of the patients measure calculated, maybe that would be useful. But only 2 measures could be calculated over 1% for over 1% of patients. Those are both tobacco-related, general medicine measures, which they've probably been reporting for other quality measures for years. And we found that we could calculate that for about 1/3 of patients. And I should just point out that 1/3 of patients probably represents all of the smokers, or nearly all the smokers in the system. And if they don't have a lot of data on tobacco, cessation counseling for the non-smokers, that's kind of understandable that the data would be missing. So, about a third of those measures being calculable is actually really, really good for tobacco. But there was a big cliff after tobacco for all the rest of the data elements.
I see.
So the other measures, like for radiation therapy, the data might be in a completely different module or a different database system entirely, or measures related to the coordination of care, potentially across different sites. They had such low fill rates that they were essentially impossible to calculate. When I say calculate, we came up with a very simple analysis called calculability that basically said, for example, if any one of the data elements that's required to calculate that measure had a 0 fill rate, the entire measure can't be calculated.
That makes sense.
And so we had a lot of data elements with no data in them at all. And so that resulted in a lot of completely non-calculable MIPS measures.
I see. Wow. That's pretty stunning, I must say. So Anna, what's your take on this? Why do you think the results were really this optimal, or let's call it what it is? Why were they this poor?
Well, not to be obvious, it's because the data fields just don't fill themselves. They have to be filled actively by some kind of entry process. Now, data elements that relate to billing are usually sort of they're built into the workflow. When the practice first enrolls a patient, all their billing information gets put into data fields. So it's not surprising that all that stuff showed up. And there are some other kinds of data elements that it's technically pretty trivial to do an interface between a routine laboratory piece of equipment and the EHR. Once that's been set up one time, exporting it out of a machine and into the EHR, it's a no-brainer. Theoretically, laboratory results that come from the outside, from a reference laboratory, it certainly could easily be imported also. And there are situations and there are institutions that are working with some of the big reference laboratories to get the information brought in. But I have to point out, every single institution that uses a vendor's EHR is going to do some custom implementations, and the importation is not something that's an off-the-shelf offering right now. There's a lot of really important information in the pathology stuff that's in text, and theoretically that could also be interfaced, but it isn't. And there are, as Rich was mentioning, and I think you mentioned too, Bob, you know, if it's in an outside system, let's say a practice refers a patient to hospice. Well, hospice has a lot of information about its patients. They have to, by law, send an electronic report to the payer every month, describing who's enrolled, who's alive, all that information. Yet they never send it back to the referring facility. So all the measures related to hospice patients are missing in our data.
Wow. And obviously that's a critically important part of oncology care that, you know, that's just sort of structurally not even there because of that deficiency you just noted.
Yeah, I have one other thing.
Yeah.
Some things, some concepts in medical oncology, the concepts themselves are pretty vague. For example, the idea of a high risk patient or treatment intent or line of therapy. We as a community haven't really come together to say what black and white does that mean. And since we haven't come together around the concept, needless to say, we don't have a name for it. So those are hard things to put into a data field.
I see.
Too.
Okay, now that makes perfect sense. So, you know, we've been talking largely about documentation and systems, but this is really about quality measurements, really about clinical practice. So Anna, I mean, what do you see as the implications of these findings on clinical practice, and are there any potential solutions that the authors considered?
There are certainly solutions. I think the first thing is we have to accept that quality measures are not going to go away. So we have to live with those. Personally, I don't think it's fair to pick on or to penalize the clinicians because of the way the system has been configured. I think that the incentives should really be targeting the people who have the potential to improve the data capture. And I think practice administrators should really see structured data as part of the and interfaces. They should see that as part of the cost of business and plan for it and plan for bringing the data in when necessary. I absolutely would not recommend that we wholesale try to standardize the EHRs across the entire country. I think people struggle right now with keeping track of their own EHR, and we don't want to mess up people's flow. We want the clinicians to be familiar with and comfortable with the EHR they've got. And above all, I think it's absolutely a non-starter to ask that data that exists in structure someplace ever be re-entered manually by clinicians. So if it's in a report, such as a lab report or something like that, it should be brought in by an interface. If it's in a text note, I think we ought to be looking towards technologies, natural language processing or something like that, to help pull the data out of narrative and put it into data fields. And actually, Rich, my treasured colleague, you know, working with CAP, the pathologists have really made a spectacular example with the synoptic path reports. From my perspective, it'd be great if the radiologists would do something similar.
Yeah, Rich, I did want to ask you about that. So the College of American Pathologists or CAP has developed these computer readable versions of their cancer protocols and for synoptic reporting for pathologists. Do you think something like this would be applicable to oncology, or where does that fit into this discussion we're having here?
I think it can be applicable, but the success depends on the adoption of standards, and people have to be willing to, answer certain kinds of questions in a standard way for a particular kind of disease. And so there's some social factors to get over in order to make that happen in oncology. But in pathology, what really drove those social factors is the fact that the CAP cancer protocols, the data elements inside the CAP cancer protocols are required for accreditation, first by the Commission on Cancer, American College of Surgeons, and then by the College of American Pathologists. And so the computerized version of the cancer protocols, the electronic cancer checklists, they make it easier to satisfy those accreditation requirements. And those were major drivers and still are major drivers for recording that standardized structured data. So for adoption in oncology, you'd have to figure out how to do something similar to that. I think there has to be some kind of incentive to pull that off.
Yeah, that makes sense. And I think that's an important difference that you've highlighted there. So, well, this has been very enlightening to hear what your findings were in this paper, and, you know, needless to say, somewhat disappointing to see the current state of play in this space. But, and then Rich, any concluding remarks or reactions that you'd like to share? Anna.
Two things. Number one, I think the people who are putting the quality measures together need a reality check so that what they're designing and the way they word the design of the metric, it matches up with what's actually extractable, or maybe the design of those things should be at least consulted to people with knowledge of oncology and informatics. On the other hand, I think Rich and I are both hopeful that this will motivate health systems to commit resources to better capture data. And I think we've started to highlight some of the critical data elements that ought to be prioritized. Rich?
Yes, so you know, from our background with the electronic cancer checklists, they're now called electronic cancer protocols, a slight name change for the future. But there are three things that I think that are important in getting really good standardized structured data into EHR systems. And one is, first of all, you got to create those data entry standards that don't just come, you can't just pull them out of the air. You have to have expert committees developing really good templates for what kind of data that goes in. You absolutely have to minimize the data entry burden for clinicians. If anything, it should be a negative burden. It should make your life easier.
Right.
And then finally, I think, you know, the system needs to reward clinicians for using really good data standards and promoting the, you know, the public good through quality measures and really good data for research and registries and things like that. So those three things: data standards, taking heed of the data entry burden, and then some kind of reward system for actually doing, you know, improving the practice of medicine through data standards.
Well, it's nice to end on a little ray of hope, I guess. So, well, thank you both for sharing your insights about your paper. As a reminder, links to all CancerLinQ related publications, including this paper, can be found at www.cancerlinq.org/scientific-publications. And as I mentioned, we will put the actual link to this paper in the notes for this podcast. And thank you to the audience for your attention.